Okay, Bismillah. This is the second session in the emergency online course for FRCR 2B or any Arab board. In the last session, we covered a part of GI emergencies, which is intestinal obstruction. Of course, intestinal obstruction couldn't be covered within 1 hour. It needs many hours. But we covered the main approaches, how to approach cases of IO. Today, another emergency in the GI, which is acute inflammation within the abdomen. Whatever the organ inflamed, how to approach these cases, what are the expected complications to be mentioned, and any specific points regarding the management. We will try to cover this point today. Okay, starting with my friend, the big boss, Dr. Amiga, you can ask for control.
Yes, sir. Yes. Yes, I've requested.
Okay, and I accepted. Okay, acute abdominal pain for 3 days.
Okay, so here I'm provided with axial CT abdomen post-contrast images of this patient who is presented with acute abdominal pain. These are taken in the portovenous phase, and I can see that there is a nasogastric tube noted with its tip placed in the stomach, correctly placed in the stomach. Okay, no oral contrast has been given. I would just quickly go through the entire stack of images before giving my final comments. I will just go to the last cut. Okay. Okay. So here I can see on these images, I can see that the pancreatic outline is not well defined, and I can see that there is a heterogeneously hypodense collection noted in the lesser sac region. And there's also fat stranding noted in the there's also mesenteric fat stranding noted, and there is also thickening of the anterior renal fascia seen, and all these findings are in suggestive, and there is also thickening of the reactive thickening of the walls of the stomach noted as well.
Reactive, yes, reactive thickening of the gastric wall.
Yeah,
Okay.
so these are pointing towards acute pancreatitis. However, I would like to see the gallbladder to look for any calculus, which is a possible cause for this pancreatitis.
Uh, any history you want to ask about? Because
So,
I
so
don't see gallstones.
yes, sir. And the liver is also non-cirrhotic. So alcoholism, even the alcoholism
Yes,
doesn't seem
yes,
to be
yes.
a possible
He
cause in
is
this.
alcoholic. He's alcoholic. Good.
Okay. Okay. So okay, fine. So if the patient is alcoholic, definitely this is in keeping as a most probable cause for pancreatitis, and there is a large amount of fluid noted in the lesser sac. Also, in my routine practice, I would like to rule out any complications. I would look for any thrombosis of the portal vein. I'm just tracing the entire course of portal vein to look for.
I will stop you here, please. Okay.
Yes,
Before
sir.
going to the complications, we have to determine the type of pancreatitis.
Yes, sir. So this is okay. I can see that there are some non-enhancing areas noted in
Yes, yeah.
in
You
the body
see,
and the
this
body.
is early finding, boss. Okay.
Yes, sir. So
Okay.
these are some non-enhancing areas noted in the
Good.
body and tail of pancreas. This is in keeping with necrotizing
Good.
pancreatitis.
Good.
And okay, now I would check for any complications related to this. I'm looking for the portal vein to look for any portal
Good.
venous thrombosis, which I'm not able to see in this. I would check the arteries, superior mesenteric artery, to look for any SMA, superior mesenteric artery pseudoaneurysm, which can develop as a possible
What
complication.
other sites for pseudoaneurysm formation?
Uh, I think in
Splenic
pseudoaneurysm,
and gastroduodenal. Splenic and
okay,
gastroduodenal. More
then I
common
can,
than than superior mesenteric. Very good. Very
yes,
good.
and
So you mentioned some complications, vascular complications,
yes,
like hemorrhagic pancreatitis, pseudoaneurysm formation, and venous thrombosis. What other complications?
yes, okay, so and yes, I can see that there is a large amount of fluid noted
Good.
in the peritoneal cavity, and I can see that.
Regarding the fluid here, large amount of fluid in a pancreatic and peripancreatic, and this is a necrotizing pancreatitis. Does it have a name, this collection in the
Yes.
pancreas and around?
So I think, sir.
Acute necrotic collection. Okay, I will mention this in a minute. Good, good.
Yes, sir.
Remaining complications
Yes, sir.
are
Yes, sir. Yes, I can see that even the kidneys are hyper-enhancing, and also,
very good, very
yeah,
good. Is
there
the
is a slit
patient
like
in
kidney
shock
stone.
or no? Good,
Yes,
good.
sir. This suggests that the patient is in shock because the IVC appears to be slit-like, and there's hyper-enhancement of the bilateral kidney. So this is in keeping with
And adrenals also.
shock. Yes, sir. And
Very
yes, the adrenals are hyper-enhancing. So I think that patient is having hypoperfusion complex,
excellent,
is
excellent.
evident on.
Management,
So I'd urgently convey my finding to the referring physician. Will need urgent surgical referral.
good,
Uh,
good.
and
Any idea about CT scoring system? This is a new possible question.
Yes, so CT scoring system, we scored like if it first we see if there is peripancreatic
Good,
fluid collection is there, then it makes it four. I will give you 4 points on that. Then if it is less than 30% necrosis or more than 30%
excellent.
of necrosis, then if since I can see that this is involving more than 30% of the pancreas, so I think yes, it will. I will again score 4 on that, and then there are extra. I would look for any like the patient is having
Ascites or effusion, for
ascites
example.
and the
Very
pleural
good.
effusion. The additional 2 points have to be given for that. So this makes CT scoring
Very good.
total scoring of 10. So this is
Very,
a great prognosis, and this patient needs urgent surgical referral.
very good. Very
Also
good, my friend.
correlate with the lipase
Yes.
amylase levels.
Yes, very good. Excellent, my friend. Excellent. So we started the first case, of course, with the big boss. It's a little bit difficult case. Can I take my mouse back?
Yes, sir, please, sir.
Okay. Just yes. Okay, we have two types of pancreatitis. A simple type is the edematous type, okay, or interstitial type. Just an area of inflammation, smudging of the fat, increase the size of pancreas, plus or minus collections, but normal enhancement of the pancreatic parenchyma from the head to the tail. Very important point to be mentioned early in description, so you will not forget about it. Here in this case, the head normally enhancing part of the body and the remaining part of the body until non-enhancing. Instead, we have a fluid collection in its expected location. Non-enhancing part of the pancreas is a necrotic pancreatitis. So this is the first point to be determined, the type of pancreatitis. Then describe other finding like collection within the parenchyma, around the parenchyma, any complications, local complications like venous thrombosis, assess the superior mesenteric, splenic, portal vein, and also pseudoaneurysm formation, and how to rule out hemorrhagic pancreas in the pre-contrast study if hyperdensity in the pre-contrast trial. So it's important to mention this point also. Vascular complications, local complications, fluid collections. I will mention this in a minute. Reactive thickening is a normal. Reactive thickening is accepted finding. Reactive thickening of the gallbladder, reactive thickening of the duodenum. You see, my friend, there is reactive thickening of the whole duodenum and sometimes of the gastric wall. This is accepted findings. Okay. Any case of severe inflammation, any case of abdominal trauma, perforated ulcer, please rupture the viscous. Please, my friends, do not forget to comment on shock syndrome, plus or minus shock syndrome. I think you remember the items of shock syndrome: hyper enhancing kidneys, persistent nephrogram, hyper enhancing adrenal glands, collapsed IVC, and if we go down, thickened hyper enhancing bowel wall as well. Just to revise this area, because this is an important and common exam case, we have so many complications in pancreatitis, like fluid collection. But you see, the first point determine if there is necrosis or no. Then fluid collection. If fluid collection, okay, in edematous pancreatitis, interstitial pancreatitis, it has one of two names: acute peripancreatic collection or pseudocyst. The difference between both is a timing. And in imaging, wall enhancement. Here, no wall in the first 4 weeks, so acute collection, and here there is a wall, pseudocyst formation. Okay, and if lack of enhancement, it's a necrotic pancreatitis. Yearly acute necrotic collection. And later on, if it become having a wall-like, it's called wall of necrosis. Just to revise the nomenclature. Sometimes maybe asked about CT scoring system. We comment on the number of fluids, presence of ascites and effusion, and of course, necrosis. Necrosis is very important, and it score high grading. We have CT severity index and the modified index in Radiopedia. Okay, like I think this one from Radiopedia. Just revise. If you don't remember, no problem in the exam. Just mention the points itself. I'll comment on the necrosis. I comment on the number of fluid collection. Then I revise the internet to put a scoring system. And from the scoring system, we classify it into mild, moderate, severe, and the management differs accordingly. Okay. Thank you, Dr. Omega. Well done. Well done, my friend.
Thank you, sir.
Okay, the next candidate, easy case.
Assalamu alaikum.
عليكم السلام ورحمة الله وبركاته. How are you, يا boss?
I'm fine.
Okay. Ask for control.
I request it.
Okay, just to mention the history, we have some abdominal pain. Okay.
Okay. And with history of pancreatitis.
Yes.
Okay.
Proceed.
So I am provided with the CT scan, axial images, portovenous phase. First, I am scrolling all of the images, then I will my findings. So this is the first image in which I can appreciate that there is the left-sided perforation, mild. There is a collection noted at the tail of the pancreas with air locules in it. So this is the area of interest for me, in which I can appreciate that pancreatic outline is not well defined. There is a peripancreatic fat stranding in peripancreatic fat haziness with the peripancreatic fluid as well. There is a collection with the air locules in it at the tail of the pancreas.
An important point to be mentioned.
I am looking.
What about the enhancement of the pancreas?
Yes, the pancreas head and proximal body is enhancing. Even the tail, distal body is also enhancing, but tail of the pancreas I cannot definitely
it's
identify.
not seen at all. It's not
Yes,
seen.
it
The
is
tail
not
of the
seen.
pancreas, it's not seen at all. What does it mean? It means
It means that there is some necrotic component at the tail of the pancreas with formation of an abscess at this level. I will confirm my findings if it is an abscess or if it is any fistulous communication with the adjacent bowel loops.
Good.
There are multiple collections which are seen in the peripancreatic region, in the celiac axis, and in the around the superior mesenteric vessels as well. I am looking for the other vistas as well. No lesion in the liver parenchyma, no abscess formation. Gallbladder is normal.
When to perform a CT if suspected pancreatitis? In the first day of suspicion?
When there is any complication, then CT pancreatic protocol is going to be performed.
Okay,
So I'm looking for
how to know? And for example, what another question, what are the diagnostic criteria of pancreatitis in general, not in imaging? How to diagnose pancreatitis? Clinical, lab, imaging, correct?
Clinically, patient present with the pain, and in the lab, there should be a malaise
epigastric pain that may relieved on leaning forward. Very good. And laboratory data like?
And lipase and amylase level should be raised in the case of
above
pancreatitis.
3 times or more. Very good.
3 times,
yes. Two criteria is enough to make the diagnosis. So imaging is not necessary for diagnosis of pancreatitis. Yes. If you diagnose the pancreatitis on clinical and lab, no need for imaging in the first day. But when? After 3 days. Because necrosis will not appear except after 3 days. Okay, my friends, complications starting from necrosis appear after 3 days, not before. Okay, very good. Okay. So a question here, how to differentiate between infected necrosis and pancreatic abscess?
In infected necrosis, I think there is, first of all, there should be a pseudocyst or a vault of collection and a superadded infection. It is called necrotic abscess.
If area of necrosis, it's infected necrosis. Abscess, usually the rest of pancreas is normally enhancing. No abnormal enhancement, no hypo enhancement. But there is a well-defined collection that containing air foci. This is a pancreatic abscess. But it's commonly now diagnosed as infected necrosis. Okay, my friend? Very good, okay. Very good. So this is a case of infected necrosis where we can find a collection replacing the pancreatic tail. No enhancement at the pancreatic tail, and instead ill-defined collection containing air foci. So it's an infected collection. What about this focus? This hyperdense focus, what does it mean?
It could be aneurysm.
No. It's calcific.
It could be hemorrhagic. Okay, yes, it is calcific.
Okay. Calcific. It means we have previous attacks. It may represent
chronic pancreatitis.
Very good, very good. Okay. And also to rule out the complication, no venous thrombosis, no pseudoaneurysm formation, and no shock syndrome. Okay. Yes. Normal enhancement of the kidney, adrenal, and bowel. Mild effusion. Very good, my friend. Well done. Management, just to finalize the case.
Yes, I will convey my findings to the referring physician and to recommend the patient to the surgical consultation because it is an emergency.
Very good. Okay. I'll give you another case, easy one. Okay. You can scroll.
So I am provided with a CT scan, axial images, contrast enhanced study in the portovenous phase, in which I can appreciate there is biliary duct dilatation.
Good.
So I will going down to see all the images. The area of interest is at the porta hepatis and in the peripancreatic region. So this is the area of interest in which I can appreciate that there are multiple areas and foci of calcification noted at the head of pancreas.
Denoting?
Denoting chronic pancreatitis, head of pancreas and whole of the body of the pancreas, suggestive of chronic pancreatitis. There is peripancreatic fat straining as well. I can appreciate that there is a large contrast-filled structure noted along the head of the pancreas, which is likely an aneurysm. I am looking, I think it is the aneurysm of hepatic
aneurysm
artery.
Or pseudoaneurysm?
Pseudoaneurysm.
Yes, it's a complication. Good. Of
With sound.
which artery?
Sir, I'm looking here. There is it could be.
What are the commonest sites for pseudoaneurysm complicating pancreatitis?
Pseudoaneurysm of hepatic artery
No.
or
Splenic,
inferior
gastroduodenal.
pancreatic
Splenic and
gastroduodenal.
gastroduodenal.
Sorry.
Trace this artery. Trace this one. Can I take the control?
Yes,
Yes.
sir.
Yes. Okay. By the way,
Yes,
well
sir.
done. And just leave it, leave it. Yes. Oh, good, good, good. Okay. It's better assessed, of course, in the arterial phase. So I'll go to arterial. You see a pseudoaneurysm occupying the pancreatic head and compressing the CBD, causing some biliary obstruction. It arises from this branch, and this branch arising from hepatic, common hepatic and
artery.
hepatic proper.
Common hepatic artery.
So it's gastroduodenal, a branch from
Gastroduodenal.
hepatic. Okay. Well done,
Okay,
my
sir.
friend. It's acute on top of chronic with pseudoaneurysm formation. MashaAllah. Very good. Management.
Sir, I will convey my findings to the referring physician and also convey to take a consultation from the IR consultant.
Good, good. Intervention
for
radiology.
embolization.
Yes, intervention radiology will interfere in this case. Very good, my friend. Very good. The next candidate. So pancreatitis is an important topic, very important topic in practice and in exam. Prepare
Yes, sir,
yourself
I'm
for
next
some
candidate.
complications. How are you, my friend?
I'm fine, thank you, sir.
Okay, let's see this case. I think we have some history, acute abdominal pain. Okay, ask for control. Yes. No answers, please, in the chat box. Anyone can answer on Facebook comments, it's okay. But in the chat box of Zoom, no answers, please. Okay, my friend, we have acute abdominal pain and fever.
So I have been provided with post-contrast CT images of a patient who presented with acute abdominal pain. I'll scroll through the images, then I'll mention my findings. I'll scroll to the last cut. So as I scroll through the images, I can see there are multiple air-filled diverticular outpouching of the sigmoid colon.
Good.
I can also see there's a large fluid collection with air fluid level and peripheral enhancement seen in the related part of the mesentery.
Show your friend with the mouth, okay?
Here,
for your
this
friends.
collection.
So it's a solitary?
No, it's a branching collection.
Just one collection or?
Multiple, sir. There are
Okay.
multiple collections and they are branching.
Okay. And of course,
They are
smudging of the
surrounded.
fat planes.
They
Okay.
are surrounded by heaviness and stranding of fat planes, suggesting inflammatory nature.
Good.
So my provisional diagnosis for this case would be acute diverticulitis complicated by perforation. So I'll scroll through the rest of the images to see if there is any associated complications, such as thrombophlebitis of the inferior
Good.
mesenteric vein.
What else as a complications you should look for?
I'll ask for the lung window to see if there is
Good.
any pneumoperitoneum.
Good.
Okay, I'll scroll through the rest of the image, see if there are any air foci under the diaphragm. I can't appreciate any air foci.
Okay, I'll give you back.
So I'll change. I'll change again to the soft tissue window to see if there is any associated fistula tract with the surrounding viscera or any
Good.
pelvic organs.
Anything important in the upper abdomen? In the liver, portal vein? No, it's clear here, but you should tell me.
So I'm looking for the portal vein and superior mesenteric vein. Actually, I can't see any thrombus or any
Good.
filling defect. Um,
And
I can't
also,
see any.
very important to assess the liver for.
If there are associated hepatic abscesses.
Yes, yes, it's an important complication. Good.
Yes.
You can finalize now and
Uh,
management.
so, so my final diagnosis would be a case of acute diverticulitis complicated by perforation. I'll urgently convey these findings to the referring physician at this patient and also the interventional radiology team.
Good.
If they would do ultrasound guided or image guided drainage for these
Good.
collections.
Good, 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 my friend. Very good. So it's a case of diverticulitis. The main abnormality here is the presence of a multiple air-filled diverticuli, some of them filled with fecolith. Okay, this hyperdense structure, either a contrast or fecolith. It starts usually as a fecolith that obstruct the diverticulum, usually like this one feculus obstruct, then perforation occur, and abscess formation occur after this one. We have many abscess formation in the peritoneal cavity. You see this ring enhancing lesion, and back in the posterior aspect, another ring enhancing lesion, and close to the area of affection, air fluid collection, another air fluid level within a collection. So we have a multiple peritoneal abscess. Okay. Sometimes intervention radiology, sometimes surgery. Okay. Very good, my friends. This is one of the complication. Venous thrombosis also in the mesenteric and portal circulation, and the hepatic abscess formation. And very important to mention lung window to assess for a pneumoperitoneum. Okay, a clear perforation. Very good, my friend. I'll give you another case to look for another complication, acute abdominal pain. You can scroll.
So I have been provided with the post-contrast CT images of a patient who presented with abdominal pain. I'll scroll through the images and I'll mention my findings. So I'm scrolling down to the last cut.
What type of contrast given to this patient?
This is rectal contrast as well
Good.
as IV contrast. So as I scroll through the images,
And
there are
oral
multiple.
contrast. And oral
Yes.
contrast. So it's called triple contrast. IV, oral, and rectal contrast. Very good. So whenever you see rectal contrast in the exam, the problem most likely down. Okay. What do you see here?
I see here multiple diverticular outpouching related to the sigmoid colon, surrounded by heaviness and stranding of fat planes. I can
Show
see
me.
also,
Yes. Yes.
yes,
Good.
this cut.
Good.
I also can see there is a marked approximation of the sigmoid colon to the bladder here in this cut,
Good.
with air foci seen inside the bladder.
Yes. Air
Um,
within the bladder in absence of
in absence of catheter.
Yes. Because if catheter is seen in the bladder, maybe iatrogenic. But here, no catheter, which means
This suggests the presence of a fistula tract between the sigmoid colon and the bladder. This
good.
might be a complication of acute diverticulitis.
Good.
I also see if there is any associated air foci in other pelvic organ. I can't see any air foci in abnormal location other than the bladder. So I'll scroll through the rest of the images to see if there's any other complication, like inferior mesenteric vein thrombosis, hepatic abscesses, or pneumoperitoneum. I'll scroll through the upper abdominal cuts to see if there are any associated mentioned complication from what I
Good.
said before.
Good.
I can't see any other complication. So my final diagnosis here would be acute diverticulitis complicated by a fistulous tract between the sigmoid
Colovesical.
colon and the bladder.
Colovesical fistula. Very good. Very good. For surgical and urological referral to
Yes.
determine the first arrangement. Excellent, my friend. Excellent, my friend.
Thank you, sir. Thank you, sir.
Okay. Just give me the mouse. Okay.
Okay.
Okay. Yes. Okay. So another important topic also in the area of inflammation is a diverticulitis. Diverticulitis can complicate locally by pericolic abscess formation, local perforation, or colovesical fistula. It can by the way, it can form fistula with many organs. But commonly, the bladder. It can be a gynecological one or colic fistula or cutaneous, whatever. Another complication, secondary abscess away from it. It may be gynecological or commonly liver abscess, commonly multiple liver abscesses, venous thrombosis. Another complication may be IO or lower GI bleeding. This is another type of cases. We will cover this in a minute. Okay, well done, my friend. The next candidate.
Yes, doctor.
Okay, this patient has acute abdominal pain.
Okay. I'm presented with a frontal radiograph of the abdomen of a skeletally mature patient complaining of abdominal pain. I can see multiple dilated gas-filled small bowel loops, mainly on the left side of the abdomen. I can see I do not see any surgical clips. I do not see any radio opaque calcular shadows. In my routine practice, I would extend.
You are suspecting
Oh,
what type of IO? Small or
it's
large?
larger. Oh,
Okay. So what is the
it's larger,
what is the common causes of large bowel obstruction?
volvulus, but I do not see.
No,
No, I do not see.
not volvulus.
It's not in this case, not volvulus, but I'm thinking about other causes of large.
Cancer until proven
Oh,
otherwise. Okay, colorectal carcinoma responsible for more than 50 or 60% of cases of large bowel obstruction. So the first point, you mentioned dilated bowel loops and multiple air fluid level at the periphery with incomplete, widely separated mucosal folds. It means haustra. So I'm suggesting large bowel obstruction, then mention the causes. Cancer, which will be revealed on a CT scan, not in this study. Diverticulitis with a stricture, also in CT. Other causes like volvulus, it is not classic for volvulus. Less common causes are the small bowel causes, like obstruction, radiopaque shadow, yes, feculus, large feculus, for example, not gallstone ileus. Okay, my friend? Okay, so it's a case of large bowel obstruction and it has a different approach than small bowel. Very good. If large bowel and small bowel, you may look for surgical clips because it may be generalized ileus as a post-operative states. Okay, what you will do next? A CT scan, of course.
CT scan.
Okay, you can scroll.
I'm presented with axial CT scan of the same patient in portovenous phase. There is.
Are you sure
Scrolling
portovenous?
from. Oh, it's non-contrast.
Yes, no IV contrast, just oral contrast is given. Good.
Okay, so I'm scrolling from up down to check for the abnormality. I can see the dilated large bowel loops, ascending, descending colon, transverse. There is surrounding fat stranding on the left side.
Good.
I am checking if there is any transitional point or if there is any mass. I can see here this is a transitional point. This area. It's looks like going down. It looks like a short segment with shouldering. Uh, there is no significant surrounding fat stranding at this area.
Are you
There
sure
is
no
intramural.
significant fat stranding?
Yeah.
I see fat stranding.
Yes. Here.
Okay.
Yes. Okay.
Okay.
Okay. There is intramural air also. So
Is it
this in old age,
intramural air or diverticuli?
diverticulitis.
Yes,
So
because
it
it's
could
different. Good.
be
Mm.
it could be a case of chronic diverticulitis complicated associated with uh, sigmoid carcinoma at the sigmoid junction.
Or stricture.
I,
Very good.
or
Very good. Very good. So
yes.
it may be diverticular stricture, secondary to diverticulitis, or it may be colorectal carcinoma on top of pre-existing diverticulosis. Very good. Very good. What you will do, complete the comment, then tell me the management.
I do not see any surrounding lymph nodes at this
Good. No
area.
significant enlarged lymphadenopathy. Good.
I do not see other areas of stricture. So I will go for rectal contrast to check for this.
Okay. Good point. Okay. What else?
I will add also. I would also add this IV contrast to check for the enhancement of this dilated bowel loops and check for any complications.
Like what?
If there is venous thrombosis,
Good.
because it looks like there is associated inflammation.
Assess the
I would
liver
like
for
to
any abscess or any
abscess.
lesion
Yes, yes.
or any
Check.
metastasis, for example.
Yes,
Good.
yes. Check portal vein for thrombosis in a liver metastasis. I would like to check also for in lung window if there is any associated, if complicated perforation.
And
Uh,
you put a possibility of colorectal carcinoma, so
of
lung window.
colorectal carcinoma, so
Lung
lung
window.
window will be beneficial in assessing if there is any lung metastasis.
Good.
In the
Good.
basal lung cuts, I couldn't
Good.
see any lung
Very good. And also
metastasis and no pleural
bone window.
effusion.
Bone window. Since
I
you
will also,
mentioned the possibility of a colon cancer, complete the case
yes,
searching for any metastasis. It's very good, my friend. Very
yes.
good. So the next step will be
Um, um, the colonoscopy,
yes,
after the
yes,
CT with contrast, colonoscopic biopsy,
yes,
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 for
yes.
staging.
No, 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 no. It's not
CT
cancer. For confirmation, biopsy,
for
histopathological
confirmation.
correlation. Is it cancer or just stricture? It was a stricture. This case is a diverticular
Yes.
stricture, not cancer. But you are correct.
Mm.
You are correct. Colorectal carcinoma is more common than
Yes.
diverticular disease. Okay, but we have
Yes.
signs of diverticulitis. Very good, my friend. So just to revise the complications: abscess formation, fistula formation, obstruction, whether a small bowel or a large bowel. But remember, my friends, generally, if you face a case of a small bowel obstruction, usually we go from up downward, looking for the transition point, which is commonly either at the duodenum, for example, as in Bouvret syndrome, or at the ileum, as in gallstone ileus. If you see a large bowel obstruction, usually we go from down upwards, looking for the transitional point. It will be easy if we
Yes.
start from down upwards. Okay. Nice, my
Okay.
friend. Another case, but this time the patient presented with rectal bleeding. Before I'll give you this case, I have arterial and venous. What are the expected causes you should look for?
In old age with rectal bleeding, first cancer colon also,
Good.
and this is an angiodysplasia
Good.
of the colon. So
What
I will
else?
check.
Okay, look for this case and tell me what else, because another cause. Okay, you can proceed.
Okay.
So bleeding is an important emergency case also. Okay.
Yes. Okay. So basal lung cuts look no lung nodules, no pleural effusion. So I will go down, start from up to
You
down.
should mention the phase. Which phase is this?
Oh, arterial. This
Good.
arterial phase. Yes. Incidental right renal cyst. There is calcular stone in gallbladder also. Pancreas looks fine. Other kidney looks fine. So I will go directly to the colon.
Yes. As you should
I can
assess the
see.
colon step by step. Very good.
Okay. So I will start from. Oh, sorry, it's going to. Should I? Okay, also there is a sigmoid, also diverticulosis. Okay, so I will start from the rectum. Yeah, okay.
Okay.
Upward. Okay, going up. Going to sigmoid looks the diverticulosis and also surrounding fat stranding.
Okay. What you are looking in the arterial phase in case of rectal bleeding or unexplained anemia, another type of history.
If there is any active extravasation inside the lumen or this.
Very good, very good. Go down, my friend, because of time, because ascending and descending doesn't have any extravasation. Look at the sigmoid.
Oh, there is here active.
Use the
Here
point.
active extravasation.
Yes. And it's surrounded by multiple diverticuli.
Yes. So
do you see any
could be
mass?
I do not see any mass here.
Very good. So another cause of bleeding, diverticular disease. Okay,
Yes.
just to remember. Okay, one of the complications, lower GI hemorrhage. But you have very good approach. Commonly in the exam, angiodysplasia, colonic angiodysplasia. But you should look for other causes like diverticular disease, cancer, ulcerative colitis. Okay, what you will do next to confirm?
I will check this maximum intensity projection to confirm this, to check the bleeder.
Venous phase
Venous phase. Yes.
Okay.
Venous phase. The bleeding, it's increasing in the venous phase, so it's going with active bleeding.
Yes. Now pooling, excessive pooling is noted. Okay. So what is your diagnosis and next step?
So this is a case of sigmoid diverticulitis, complicated by this is pseudo aneurysm.
No. Just hemorrhage.
Or active bleeding. It's just
hemorrhage.
So I will convey. Yes, convey the finding to the referring physician. This is emergency, and I should inform the interventional radiology team for possible embolization of the bleeder.
Yes, very good, my friend. Very good. You see, my friend, okay, we are just putting some rules for study and for assessing the CT studies or GI emergencies. Look for the inflammatory source and try to rule out the complications one by one. My advice to you is to see Radiopedia, for example, a topic like diverticulitis. See some cases and as much as you can complications. Okay, يعني ما شاء الله يعني راديوبيديا جزاهم الله خيرا full of cases and full of complications. Okay, we covered now 3 candidates. We have another 3, so I will close this record and open another one.